are. Welcome back to On Air with Dr. Pete. I'm your host, Dr. Pete Economo, and I want to thank all of you for tuning in this week. As many of you know, September is National Suicide Prevention Month, and we are here today to continue to raise awareness, spread hope, and take action in suicide prevention and all things mental health. This is a powerful reminder that we must all contribute in looking out for our loved ones and people around us in the community that have impacted by this leading cause of death. Yes, you heard it right. We have heard from guests in the past, and certainly May Mental Health Month and all these other things. I am very happy to introduce a very special guest today. Garra Lloyd-Lester is the coordinator of community and coalition initiatives at the Suicide Prevention Center of New York. That's a mouthful, but I mean, how amazing to have Gara here this morning to talk about this. Their mission is to promote, coordinate, and strategically advance suicide prevention across the state. So we are so happy to have you here. Thank you, Gara, for being here this morning.
Yeah, greatly appreciate the opportunity to shine a light on this topic.
Yeah, it's as a mental health provider, it's one of these topics that is like taboo, and I know like graduate students are always so afraid of it. You know, how did you get into it?
I found the work and the work found me, I guess, for lack of a better term. When I was in junior college, I had made a couple of suicide attempts. I aborted them myself, sort of put them in the rearview mirror, didn't really give them much thought. My career has always been in the helping fields, health and human services, child welfare, mental health. Fast forward from that time, about 35 years or so, I had a friend who lost her adult daughter who was a physician to suicide. And it brought about just a bunch of thoughts and emotions to realize that I might be able to play a part in this work.
Yeah. Like you said, it finds us, I think, and thanks for sharing that. So from what I understand, the center combines a clinical and a public health approach. So explain that so that the listeners can understand what that looks like.
Absolutely. So I think probably many people, if they think about suicide prevention and help, they would by default go to going to a professional, a therapist, a psychologist, right? Which is true for some people, right? That's where we would anticipate people would get help with thoughts of suicide, or if they've made an attempt to figure out strategies. However, we know that for many people experiencing thoughts of suicide or that have made an attempt, they're not necessarily connected to those mental health professionals. So therefore, we need to make sure using a public health approach, which whether it's suicide prevention, diabetes, cancer, is looking at identified risk factors that we know exist and trying to mitigate or protect against them with protective factors. And so a lot of our work in New York State, absolutely clinically focused, but my role, for example, at the center includes working with local suicide prevention coalitions to develop capacity on the local level to address suicide.
And local level, so in New York, so New York's a big state, so how does that work, you know, different boroughs or just even upstate and throughout the whole like large state there?
Yeah, absolutely. So there's 62 counties in New York, and I've had the good privilege of, I think, going to or through all of them as part of my role. And it starts with data, quite honestly. We want to empower the local communities to understand what does suicide look like in their county. We need to know what it looks like on the national level. We need to know that for prioritizing our efforts and to understand disproportionately affected populations. But the real work happens on the local level. So a lot of it is bringing partners together, local health departments, mental health, law enforcement, faith leaders, child welfare, different organizations and systems, and importantly, people with suicide-centered lived experience and expertise all need to come to the table looking at the data and coming up with a strategy, a plan, the same way that we have tackled rates of tobacco, continue to address diabetes, heart disease, et cetera.
Yeah, I was just thinking that. I mean, I think it is so critical to have an integrated approach. It's not like, and I like that you opened up by saying like it is a public health aspect and it's not just coming to a psychologist. I know the graduate students I'm training are always so afraid of this. They're, you know, and what I'll say to them is like, they'll be like, oh, they filled out the form that they had a suicidal thought. And I'm like, good, they're being honest, you know, like, you know, and so to create the clinical approach of like, people need to understand that these thoughts are normal, you know, and I want to validate that for people. It's okay to have thoughts. It's about the intent or a plan to do something. And I'm assuming that that's a big part of your education too, for these outreach.
Absolutely. If we think about the term suicide prevention, sometimes people might think about how are we preventing people from having thoughts of suicide? And I wish I could say that there was effort or the ability to do that. And we can certainly get better, right? We can teach kids resilience skills, social emotional learning skills, and coping skills. But for reasons that are unique to individuals, anyone has the potential for thoughts of suicide. The Suicide
right.
prevention at its core is about trying to intervene to prevent those thoughts from becoming actions. And so to your point, right, with your grad students, we want people to say, yeah, I've been having a hard time recently. We want that honesty because there's a belief that most people struggling with thoughts of suicide really don't want to die. They just don't know how to go on living. And so we need to be able to
Exactly. Oh, I love
have
that.
people who can
I love
support them.
that. Yeah. Yeah. They don't want to die. They just don't know how to go on living. It's important to hear that. So what are some recent stats? Like, I know as a researcher, I'm always looking stuff up, but where do you go for this? And do you guys collect your own data? And like, what are some recent stats you want to share with some listeners?
Sure. So in New York State, we do our best to make sure we have current real-time data. There's almost always at least a 2-year lag for public health data regarding any issue, whether it be, again, tobacco, et cetera. Same is true with suicide. Same is true nationally. So in New York State, we have the New York State Department of Health, which is able to give statewide information. And then nationally, it's typically the Centers for Disease Control. Just a couple of days ago, a report was released on the national level that suggested suicide rates, which is the number of individuals per 100,000. So it's not a percent, it's a rate. From 2018 to 23 decreased 7% among young people 10 to 24. It's good news, right? We saw a decrease in rates and a similar decrease in the 45 to 64-year-old. But we saw an increase of roughly 25% among Black people and 10% among Hispanic people. Now, this is nationally, right? In our conversation just a moment ago, it's important to know the national information. It's important to know statewide level, but sometimes that's not always reflected on the local level. So we need, to the best that we can, look at those local numbers and say, okay, what do we know about suicides within, Black and brown communities in New York City versus upstate New York, et cetera. And I think the other thing, just for your listeners,
a 25%. Yep. Go ahead. Sorry, I cut you off there, but a 25% increase, that is really significant.
It is. And I, don't want to be alarmist, but on the other hand, this is data that, to the best of our knowledge, is accurate based on vital statistics, right? A medical examiner, a medical death investigator has indicated that a number of people have died by suicide, right, based on their investigation. So yeah, we're not talking a 2% or an 8% increase, which any increase is going in the wrong direction, right? But 25% says, hey, we have to continue to be diligent and take a look at, like, how does suicide show up in different cultures and races, right?
Yeah.
It looks different. It sounds different, right? People talk about suicide different in tribal communities than they do in Black and brown communities. The problem exists, but how it's talked about and then how it's addressed needs to be tailored, right?
Super helpful. And even just a cliffhanger there of postvention. So, we talked a lot about prevention, but also thinking about that there is, care after. And in May, we had a couple organizations on talking about, families that have lost, someone by suicide. So, Gara, thanks again for being here. Appreciate your time. Those listening or tuning in at home, if you or someone is struggling, like Gara just mentioned, you can call or text 988. That you could be connected with a mental health crisis counselor at the Suicide and Crisis Lifeline. So really significant topic, heavy, but thank you all for being here. It's very important. As always, please tune in and share. Everything's at Official Dr. Pete, and I'll see you back here next week. Until then, spread a little kindness and stay well.